So, I have been asked to talk about pain relief after total knee replacement, which is quite an important point. And as we all know, patient primarily comes to us for a painful joint with which they can't cope. We also know that at this juncture, there is suboptimal pain control in up to 40% of our patients. It is associated with prolonged length of stay in the hospital, not only short-term but long-term patient dissatisfaction, reduced mobility, increased opioid consumption and its impact and side effects, higher adverse events, and there is some suggestion that poor perioperative pain control contributes to long-term chronic pain. Various advances have been made over the years to ensure enhanced recovery. And it would be fair to say that the traditional approaches with which I was brought up during my residency, like patient-controlled analgesia, epidurals, sciatic nerve blocks, now have fallen out of favor. Aim of any pain control regime is to deliver a clinically and cost-effective pain relief without side effects, without delay in mobilization, and minimizing the risk of opioid consumption. I was asked to give 5 key points. What I'm going to do for the next few slides is I'm going to go through the current understanding, not necessarily giving you all the evidence you can read, but every statement I have made here is based upon what is out there in literature. And if there is a key point I want to make, I have put it in bold. So there is a huge, I probably don't want to use the word craze, but there is a lot of tendency to use gabapentinoids, so that is gabapentin or pregabalin, pre-operatively for all the patients who are undergoing a knee replacement. Most of us know that these were developed primarily for epilepsy treatment, and they have been shown to work in patients with neuralgic or chronic pain. They bind to the alpha 2 delta subunit, and therefore they were thought that they would work in total knee replacement. There have been various studies which have shown that there is not really a great deal of difference between the pain levels, opioid consumption, length of stay, if you give the patients preoperatively gabapentinoids. In fact, they have been shown to increase somnolescence as well as therefore delay the mobilization. So in a nutshell, I don't think there is any proof out there which says that you should use gabapentinoids on a regular basis. What about non-steroidals and COX-2 inhibitors? As we know that COX-1 is ubiquitous, the COX-2 receptors are mainly in the areas of inflammation. You mainly want to work on these areas of inflammation. COX-2 inhibitors are safer, and therefore, rather than using any non-steroidals, specific COX-2 inhibitors are better. It has been shown that they will work well if you give them pre-operatively as well as post-operatively rather than just post-operatively. There is reasonable evidence that IV paracetamol works better than oral paracetamol, but the impact is modest. In UK, various centers have been using long-acting oral opioids like oxycodone for quite some time. And if you try and want to use them, try and use them preemptively rather than reactively because they will work. The evidence for using transdermal patches is limited, but it is out there. So that was pre-operative. What about intraoperative? I think the main focus for intraoperative pain management is on periarticular multimodal injections, or the so-called cocktails. It's quite a common practice, it's an established practice. But one should remember that the components of each of these cocktails tend to vary based upon either one's own experience or what one has been taught. The common players are a local anesthetic, usually bupivacaine, ketorolac, and adrenaline. Some people may add antibiotics, some people may add steroid. I think steroid is controversial to a certain extent. It can have impact in patients with diabetes, wound healing can be an issue, although not 100% shown. We did a recent meta-analysis where we showed that local addition of steroids is not necessarily that helpful. Some people also add morphine. It can increase nausea. This is intra-articular I'm talking about. Last but not the least is liposomal bupivacaine. There is some evidence out there. This drug has been in reasonably regular use for last 10 years or so. And Pakira Pharmaceuticals have done a lot of campaign for this, and it was used quite regularly. And now I suppose it's more or less stable. And various high volume centers feel that the impact it has is not necessarily worth the money you have to pay. I think it costs about $300. We have done a Cochrane analysis of both liposomal bupivacaine used in periarticular as well as in the nerve blocks. It does show that there is some modest improvement in the pain, and at this juncture, we have completed the largest independent study, which is a NIHR study on liposomal bupivacaine. And I would be able to share the data. I don't know the data at this juncture because the study is carried out in a proper randomized control fashion where I don't know which patient belongs to which arm. There are more than 530 patients in the study. And I'll have the analysis completed by May, and then I hope to present it at the next Knee Society meeting. Probably the most important thing about periarticular multimodal injections is the technique. For those of you who are aware of liposomal bupivacaine, they specifically say that you should use multiple injections rather than one big blob using a 18 gauge needle. So small needle, multiple sticks, and take your time and inject in each area where you know it's going to give the patient or likely to give the patient pain. It should not be something, oh, I'll also do that. Do spend time doing it. It is important. And the timing is important. I think before and after implantation. So after preparation of the cuts and then after implantation for rest of the area is important. Systemic steroids like dexamethasone seem to work because they have anti-inflammatory action and they seem to give the patient less pain and a feeling of well-being. Again, be careful with diabetics. Some people have tried intra-articular pumps. There is no strong evidence that they work and there is a risk of infection. Intrathecal opioids do work. Patients do get good pain relief, but beware, they will cause pruritus, respiratory depression, and other opioid side effects. One bit which many a times we don't talk about in terms of pain control is use of tourniquet. And some of this might be a bit controversial. So I'm going to spend next minute or two about the use of tourniquet. There was a recent Cochrane review done by Warwick Trials Unit. They included all the RCTs as well as non-randomized studies with large number of patients. And they looked at the main outcomes in terms of pain, function, health-related quality of life, and minor outcomes in terms of blood loss, economic outcome, etc. What they showed is that there was more than 10% reduction in pain if you did the surgery without tourniquet. And by the way, visual analog scale, if you use, which is the standard mode of assessment for pain control, which is 0 to 10, you need to have at least more than a point difference so that it is a meaningful or clinically meaningful difference, so 10%. So what they showed is don't use a tourniquet, your pain will be less, which is logical. They also more importantly showed that the risk of serious adverse event was probably higher. So 73% higher relative risk if you use tourniquet. And therefore, I would urge you to try and minimize the use of tourniquet for those who use it right from beginning to the end. We have stopped using tourniquet now for more than 2 years in my institute, and we have seen a good, significant difference in the pain relief, ability to walk. And genuinely, I don't think the bleeding is a problem in cementing. You flex the knee, and most of the times, and of course, I do put the tourniquet on, but I don't raise it, and I've seen the difference. What about post-operative period? Femoral nerve blocks were quite popular, but they delay mobilization. They do cause weakness of the quadriceps, increased incidence of falls, and therefore there have been cases where patients will come back with a periprosthetic fracture even during the hospital stay. Sciatic nerve blocks now are more or less obsolete. They do mask a foot drop, and therefore you don't know if you have caused a damage to the peroneal nerve. We have had some cases of heel ulcers because the patients don't get pain, but they can't move their leg. And last but not the least, when the sciatic nerve block wears off, somehow the rebound pain that patients get is quite significant. The key home message from this slide is use adductor canal block. They are superior because they are primarily sensory, they don't give any motor blockade, and therefore they do not cause any weakness in the muscles or delay the mobilization. Some people have started doing the IPAC, which is the interspace between the popliteal artery and the posterior capsule, and they add it to the ACB because ACB will primarily be giving you a pain relief over the anterior and medial side. By the way, as all of us know, patient-controlled analgesia has gone out of favor. Peripheral nerve simulation, like ultrasound-guided insertion of small gauge needles and electric leads, can be tried, but there were nearly 1 in 5 of them did fracture in the body, although they did not cause any harm in the long term. This is a single study; it's still in its infancy. Those of us who do ligament reconstruction are big believers in cryotherapy or cryocuff. I think it does have a role to play. Ivketamine or dexamethasone, I can't even pronounce that word, I just read about it, can be used in spinal anesthesia. Therefore, to summarize, my friends, what are the key take-home messages? Implementation of multimodal pain management is good. It helps in patient satisfaction, decreasing the pain scores, and facilitates early and rapid recovery. At the same time, there is no consensus on what the cocktail should include. Neuraxial anesthesia, by that I mean spinal rather than GA, peripheral nerve blocks, do work, and they should be implemented with the input from anesthetic teams. The goal should be to reduce pain and improve function with evidence-based practice, as I have said previously. Try not to have a scattergun approach. Try not to give everything to the patient because it will be difficult for you to make out which bit is working and which bit is not working. No, don't use gabapentinoids. I don't think there is any clear, evidence out there. I probably won't use local steroids. Use COX-2 and possibly IV paracetamol. Adductor canal block works. Preemptive analgesia is the key. Try and go to reduced use of tourniquet, limited time or no tourniquet. And same day mobilization is the key. If the patient can see that he or she can stand on that leg straight away after surgery on the same day within few hours, it will help the patient's morale as well as help you. Thank you.
Thank you, Professor. That was very informative.